Good evening, ladies and gentlemen. We welcome you to the second session on the topic Complications and Solutions in Implant Dentistry. We hope you all are doing well and safe with your family. Like we always do, very quickly, I would like to know your full name and the city where you reside. Very quickly, I want you to type down your name, your full name, and which city you reside. Thank you very much. You can put the same in the chat box that is there below. Good evening once again, ladies and gentlemen. Thank you for typing down your names. Warm welcome from Team DentistChannel.Online. Today's session has definitely been kept on the account of you telling us your personal interest and for the fact that you loved the first session. And hence, we have once again the master himself, Dr. Souheil Hussiani, who will be talking about on a very important topic in implant dentistry, a topic which no one really likes to cover, a topic where everyone likes to talk about the success they had in their implant cases, but no one wants to talk about the failures that were associated with implantology. And hence, once again, we have the session specially for you. Ladies and gentlemen, it's my honor and my privilege to welcome our speaker, Dr. Souheil Hussiani, once again. Most of you all know him. For the ones who don't know him, I'd like to give a quick introduction about the speaker. Dr. Souheil completed his post-graduation in prosthodontics, TMD, and implant dentistry concurrently with a Master of Science degree in oral biology from the University of Medicine and Dentistry, New Jersey Dental School, United States of America. His undergraduate degree and PhD was from Annamalai University, RM Dental College and Hospital, India. He is currently holding a part-time faculty position as an adjunct faculty at the Rogers Dental School, USA. His master's research and PhD was in the field of dental implants. His private dental office is based in Dubai, where he performs implant surgeries and prosthetic treatments. He is the founder of Implant Dentistry's Study Consortium, the first ADA-approved dental implant continuing education course in the Gulf and Middle East, an affiliate society of the International Congress of Oral Implantologists, the ICOI, and the University of Toronto. He is the chairman of the Scientific Committee, Implant Dentistry Consensus, United Arab Emirates. Since the year 1997, his experience is exclusive in implant dentistry with most of the implant systems. He's presented several lectures all across the globe, namely Harvard University, at the Pennsylvania Penn University, at the Hunan University in China, and Canada University of Toronto. He's organized socio-economic activities and dental camps in Erbil, India, Yemen, Sudan, Bangladesh, and Sharjah Central Jail. He's published several articles in the International Journal of Prosthodontics, International Dentistry, and several other publications. Once again, we're very lucky and happy to have you, Dr. Souheil. I request you to kindly start with session 2 on the topic Complications and Solutions in Implant Dentistry. Over to you, Dr. Souheil.
Thank you very much. And I'm looking forward in trying to solve this puzzle of complications and unwanted or unexpected things that happen in such a comfortable treatment that has entered our arena since 1965, which is implant dentistry. And it's very shame to know that we have so much complications and so many failures. So I think it's a very important topic to address. We start a little bit with definitions, types, and various levels, and contributing factors and escalating factors. Of course, at the end, the ultimate goal is to talk about how it happens. In terms of how to understand this complication, there is a Egyptian proverb which says, a beautiful thing is never perfect. And there is another saying, experience is the name everyone gives to his mistakes. There is another saying, unexpected undesirable problems that make a condition more harder to treat is called a complication. I slightly modified that to unexpected and undesirable things can lead to unintentionally produced by us as doctors, like iatrogenic, or patient's body expect intentionally or unintentionally, and also external factors. In our group, I'm sure everyone has complications. Some of us learn from them, while others repeat them. And my favorite one is the one I came up with, which it says, "We are imperfect and have to struggle, but we are worthy of learning from each other's mistakes and teach ours, I mean by our mistakes, to others." This is how I look at complications. Now, when we talk about classification or the types, of course, there are different types of looking at this. Fortunately, in implant dentistry, the life-threatening complication is less than 0.01%. We have hardly 5 published cases about patients who passed away because of implant dentistry. So we are mainly looking at permanent disabling or even uh, temporarily disabling complications. That's one way of looking at the classification of complications. The other way is looking at it is we have a total complication where it occurs when wrong process is done, and we have a partial complication where it occurs when part of the process is forgotten or due to knowledge, skill, and experience, it has not been performed. The unseen complication is when it occurs, the right process is carried out incorrectly, or you don't see it due to your experience that is not seen by the person who performs it or the patient who is receiving it. Now, this slide is the very, very important. Why I call it custom made? Because each individual in this arena, knowledge, skill, and experience is different. So we have to carry this with us in our complications because it's very much relevant to know how much knowledge, skill, and experience you have in the field to be able to solve your complications. There are contributing factors that we cannot avoid. People that are involved, your team, your colleagues, your friends, whoever is with you during implant performance, from the day of greeting the patient till the maintenance visits. You use in the workplace need to be fulfilled, the timing related to the organizational part of where you practice, and also the outside influence. Economy has a role, your mood, patient's mood, so many external factors. Also, there is an escalating issue where sometimes things like time make things worse, or the people around you, the staff, is not trained well enough. The materials that you use, patient is not cooperative, and the cost that you want to provide the patient with the best treatment, but the cost that the patient is offering is not even close to what you want to provide. All these are escalating factors. Now, I want to start this lecture here. This is a very, very important presentation, and it took me more than 27 years to reach to this slide. So I hope it will clarify a lot of the reasons why we have complications. So what we are going to do, we are going to predict complications before they occur. That's why this presentation is so important for us to follow carefully. When we look at the literature, we can see that the literature that talk about complications, all of them, 100% of them have implant failures in them. So implants failing It's something that we know. Implants do fail in all these articles. Now, amongst those failures, we have failures that are biological. That means it's related to the biology, either iatrogenic, or again, it's related to the patient or external factors, but the cellular activity around the implant did not succeed in creating the ideal scenario. The other complication is technical, which comes from materials, the method, the accuracy. Both of them are very high, 40 to 60% for biological and 60 to 80% for technical. These are high numbers. That means we have to pay more attention to the issue of complications. Now, if you want to be practical, when I saw the, uh, if I can remove this, when I saw the literature, around 52,300 published articles on the topic, just to make the story so ridiculous and funny, you require 1,000 years to live if you read one article per week. That means if I also want to add another lecture, which will show you another set of complications, I will be 52,301, which probably you will not read because there's enough literature on the topic. So I'm going to use another analogy in solving or predicting complications. We all know that many people go to diet and not all of them lose weight. So just because you're dieting, that doesn't mean you will lose weight. The same concept applies to teaching and learning. Not whatever I teach or anybody else teaches in terms of complications will be learned by the audience. Because just if somebody is teaching, that doesn't mean 100% of that knowledge, experience, and skills will be transferred to the person who is learning. The same thing is applied on, even though we know in the literature that implant dentistry is 97% successful, that does not mean we only have 3% complications. Our complications, 40 to 60% biological and 60 to 80% technical, is a fact that we have to understand. Now, many of you have seen this movie. It's called the Imitation Game. This movie actually helped me to create this presentation around 10 years ago. When the movie came, I don't remember when was it. The reason why this helped me was it was very difficult for the British government to find for every letter from Hitler to be decoding it so they know where the next attack is going to be. There was one person who said, I'm not going to break the code of every letter that is sent from Hitler to his soldiers. I'm going to create a machine, which became the future computer that we are using today. I'm going to create a machine where no matter whenever the code is coming, automatically that machine will translate it in an understandable, digestible manner. So my intention in this complications session is to create a methodology where all the complications can be fit in and it can be solved. Also, the other element that helped me to come to this protocol or skeleton is the invention of a navigation. Why is navigation so successful and we cannot till today, we cannot apply that to implant dentistry, that the doctor is sitting, the patient is sitting, and we turn on the navigation, and we just, the computer will tell us, okay, anesthetize, make the incision, open the flap, drill, go to the left, go to the right, speed is. Why this is not happening? Because in navigation system, the structure or the base where all this information is uh, basically applied on is the roads, is the streets. The streets are not moving. The streets are constant. They stay on the same path. And it is not something that one day the street is here and another day it takes another route on its own. With implant dentistry, the cellular activity, the resorption, the biology, uh, the the way the body reacts to the titanium, the membranes, the bone material, the vitamin D level of the patient, the consistency of the bone, the hardness, all that is changing. And because of that, no one could come up with a navigation system where you just tell what you want to do and the navigation will guide you and always you reach to your destination. So I took this navigation concept and I said, okay, how can we apply this in implant dentistry? The common uh, factor that we have is a radiograph. The radiograph is something, whether it's a panoramic, periapical, or CBCT, it's a constant figure for that minute or for that day. If we take that um, image and we use that for our base, we can create something close to navigation, and accordingly, we can know where we start and where we end. So our basic infrastructure to build this skeleton that we are going to share with each other is the radiograph of the patient. Now, from the people who are managing this um, presentation, there is one link here, but you can provide the audience with the articles, the 3 articles that I have provided for you. So now you'll be looking at 3 articles, which you can read them later, which is relevant to how we apply a formula and how we can use the radiograph to understand the complication, because that becomes our infrastructure. Now, we all know that implant dentistry have fixed steps. I divided them into 7. Some of you are not familiar with the importance of radiography and maintenance as much as the other steps, but I think all these 7 steps are necessary to understand implant dentistry. And in every step or every title, like diagnosis, radiography, surgery, uncovery, impression, restoration, and maintenance, uh, each of them have certain steps that you have to follow. During diagnosis, you have to do certain things. During radiography, you have 3 types of radiography. You should be able to provide those 3. In surgery, you have, depends on what category you're following, you have 12 steps to perform a surgery. In uncovery, the same thing. Impression, the same thing. And restoration, the same thing. And maintenance, the same thing. So knowing all the steps for every procedure is necessary to be able to predict your complications. Now, let us make this classification little easier to understand and digest. Imagine we divide the mouth into 5 uh, geographical areas. Imagine we call the anterior mandible class 1, maxillary posterior class 2, mandibular posterior class 3, anterior maxillary class 4, and class 5 becomes posterior maxilla with sinus lift. The articles that I provided will explain to you how does that classification work. Now imagine all possible procedures that you will ever do is already coded from 1 to 10. 1 being implant placement and restoration, 2 being a block graft procedure, 3 being particulate graft procedure, bone grafting, GBR, capital S, lateral window sinus lift, small s, internal sinus lift, capital X, immediate extraction, immediate implant placement, small x, extraction, waiting a healing period, and then F is standing for PRF, capital T for autogenous soft tissue grafting, and small t is a soft tissue taken from another human in a jar or in a container that you buy it and you use it. It's not autogenous. Now, once you understand all these procedures, now you have an imagination of what possible inventories you have in your skeleton. Of course, to make the presentation within 30 minutes, let's concentrate on number 1, which is implant placement and restoration. In that implant placement restoration, we have, as we mentioned, we have 7 steps. Now, between the evaluation and the surgery, there is a radiography, and we know that after the restoration is over, you have maintenance phase. Now, if you can imagine a timeline where you start here and you continue all these steps, the same time you're looking at this path, the same time you should look what you'll be doing or should be doing while you evaluate the case, while you do the surgery, while you do the uncovery, while you take the impression, how you do the restoration, and every step is important to master. It's important to understand, to learn, to do it perfectly. And again, the issue of knowledge, skill, and experience comes for each and every individual step under each procedure. So now let us look at this text in a more practical way. For example, a patient calls after this step. We've done the surgery, we sutured the area, the patient received a couple of implants, she went home, she called on the 3rd day saying that I have a swelling, and she took a photo with her mobile and sent it to the clinic. Now, if you have done all these procedures properly and you have a protocol that all of this was done accurately, then you ask the patient, did you take your anti-inflammatory or not? Did you take your antibiotic or not? If the patient says yes, do you have pain or not? If the patient doesn't have pain, then you ask the patient to keep a cold and warm pack for 4 minutes, 1 minute cold, 1 minute hot, and repeat that 3 times a day, and you call the patient the next day. And that's it. That easily solve a photograph like this because you know what you've done. Say another scenario comes where a patient comes with a broken abutment screw. You know that you have done the restoration. You know you've done all these steps properly. So what can go wrong? It's either you've gone beyond the torque level that the company recommended, which you didn't because you are following everything by protocol. So the only thing left for this to happen is assessing occlusal clearance. So you change the screw to another screw and you make sure the occlusion is done properly. Say another scenario, a patient sends another photo from home saying, I can see the bone above my teeth. Again, it's a surgical issue. The patient is called 1 week later. You're sure that you've done all these steps, but as you can see, if the bone is exposed, that means step number 11 was not properly done. So scoring was not done. Now the treatment could vary between different scenarios, because now it's a irreversible damage that you just can't patch up. But at least you know, you are predicting next time you have to improve the quality of your scoring when you're doing a bone graft. Say another periapical x-ray that you took, you find the direction of the osteotomy is almost touching the tooth. You know, if you proceed with this angulation and this position, your implant will definitely damage the distal wall of the tooth. So you look into the surgical level, the surgical steps, and you find that number 8, which is angulation correction, is to be performed. So it's irreversible. It is reversible. So you just take it out, change the angulation, and find the right position. But because you followed all the protocols, there was number 7 step, which is take a photograph after your first osteotomy drill. And because of this, you can predict the future position of the implant, and you can avoid a complication of the implant touching the tooth. Another scenario, it's a restoration issue. You take a radiograph, a panoramic radiograph, and you find spacing between the restoration and the implant. So you know which of these steps you haven't done, and accordingly you find that the metal structure is not seating. So either there is a soft tissue in the middle, and if one of them is seated, that means the impression, when the impression was done, the position of the implants were not secured in a way that the expansion of the stone and the shrinkage of the casting were not calculated for. And not to repeat the impression again, you can see how deep are these implants. So maybe you should use a multi-unit abutment, bring the level of the implants higher, and then take an impression at the abutment level, not at the implant level. So every scenario has a place. Plus that, the power of when is very important. When did this happen? It's very, very crucial to understand the power of when. Because if it happened a minute ago, or a week ago, or a month ago, there is a huge difference in how you're going to address that complication. Now, you might look at your fault, like you have done something a minute ago which was wrong, it's iatrogenic, or 1 week or 1 month, but also it could be the patient's body without patients knowing it, or the patient's negligence due to smoking or not following the diabetic medication that he's taking, or it can be some external factor, an accident or something that happened. In an accident, if it happens a minute ago, the protocol is hugely different than if it happened a month ago. So also the power of when is very important in solving any complication. For example, a patient comes with a 44 ISQ number. After, the power of when is important. If this is during the surgery, there is nothing to worry about. You're going to wait a couple of months, and you're definitely not going to do immediate loading. However, as you can see, the patient is dressed up, and this is definitely not a surgical, and you don't see any blood, and we don't look scrubbed. So that means this is not a surgical session. So if this is a uncovery session and the patient is on 44, that means the implant is not ready to be restored. So you check the vitamin D, you place a healing abutment, and ask the patient to wait another month, and you reevaluate, and you start something called progressive loading based on Carl Misch's theory, and you hopefully improve the quality of bone according to the progressive loading. Another scenario, a patient comes after, say, this patient around 11 years after this was done, and you can find the bone resorption between these two implants is gone beyond the 5 millimeter rule. So you know this is not something generalized, because his other implants are doing fine. It's only one area. So beside you add the maintenance follow-up visits with low-level laser therapy and cleaning the area. Also, you look at occlusion. Maybe there is not enough occlusal force to stimulate the bone maintenance. So you add composites, or you change. Composite will be easier because you want to evaluate the quality of the bone, and accordingly you you evaluate every 6 months. But this is irreversible, so you cannot expect this bone to grow back. What you want to do, you either want to maintain it, or you want to do augmentation, or you want to remove the implant and do another one. Just to tell you something interesting about this radiograph, there is a lot of trend today on immediate loading on the. It's been very taking a lot of interest of most of the dentists, because the patient comes, they get the implant, they get the teeth, they pay, and it's done. However, with more immediate loading implants, you have deeper grooves. And after 11 years, when I see two implants next to each other, one with deeper grooves and the others with less grooves, and the only one with deeper grooves is having such a bone resorption, maybe I would not consider very deep grooved implants on a patient which is not very keeping a good oral hygiene, or smoking, or diabetic, or medically compromised. Another case comes, you place the implants, you put the healing, you did the suture, you want to send the patient home, you look at the area, they are too close. So this is 1 minute after you place the healing. Now you have a choice to remove one implant, which I think should be done, or you reevaluate the distance between the two implants. If they are less than 2.5 millimeter, then you are jeopardizing the health of the bone there. And right there, you have to make a serious decision in what you want to do, how you want to maintain this two close implants next to each other. If this patient comes to you after 1 month, where the osseointegration has taken place, it's very difficult to remove that implant in the anterior mandible. Another scenario, a patient comes from another clinic showing you that the food is getting trapped here and here and here. So you know the doctor who placed the implant did not place them deep enough, and at the same time the restoration had areas for calculus formation, and there was a food trap from the beginning, which made the story worse. So one way is to rechange the restoration, but that will never be a permanent solution. You just can minimize the gap for food trap, but you cannot regain that bone ever. A case comes after 5 years, and you can see the bone resorption and the gingival recession is tremendous. And you know this is definitely periimplantitis to the maximum. And there is no, if it's generalized so much everywhere and the gum is inflamed, you know you have to start all over again. Or this patient, you call them as refractory cases, where you look into why this is happening, and you don't rush into making new implants unless you know the cause. Otherwise, your new implants might follow the same path. I will show you a video of this is a calcium hydroxide, which is good for bone growth. So even though it costs around $35 and it's wasted, but it's worth to show you this video. As you can see, there is a fistula, and that will definitely show you that the pocket which is there around the implant crown is related to either the margin of your crown or it is superficial. So accordingly, you change the restoration. With giving you few examples, now we want to start actually drawing the skeleton for our project, which is how we would predict complications. Now, we should imagine that implant dentistry is like a building with 7 stories. Each story is designated for its own purpose, starting with diagnosis, radiography, surgery, uncovery, impression, restoration, and maintenance. Normally the stories will start from bottom up, but for us, because maintenance is the ground floor and it's what we is constant, it doesn't stop till the patient dies, so we kept the maintenance at the bottom. And most complications occur during the surgery, so we highlighted the surgical floor. In this building, my building and yours will be different. All of them have 7 stories, but the way you want to build your own is totally in your own hands and your own the way you want to build it. It will always remain a 7-story building. Even if you leave 1 story empty, you don't do the radiography or you don't do the uncovery or you don't do the impression, you send it somewhere else. But the stories are always 7. Now, in that 7-story building, each story will have different numbers of rooms. And that is what we are talking about. So they are inside of each story is not exactly identical. They are different. Now imagine we are in the surgical room, a surgical floor, and we are in room number 3, which is the incision room. In room 3, which is the incision room, each of you have different knowledge, skill, and experience when it comes to incision. Some of you have done 10,000 incisions. Some of you have done 100 incisions. Some of you hold the blade in a vertical degree. Some of you hold it at 45 degree. Some of you use different blades, micro blades. Some of you use number 15. Some of you use, you combine 15C with 12 and accordingly. So the more knowledge, skill, and experience you have in this department of incision, okay, the more you have successful incisions done. Now, let us look at the bigger picture. Imagine this is the surgical floor, okay? In that surgical floor, the basic number 1 procedure, which is implant placement and just implant placement, it's 12 steps. So you have 12 rooms. Let's say this is the incision room that we just looked at, okay? This is the incision room, okay? Here, right here. Now imagine this is the suturing room, right? In the floor of surgery. Now, if I show you this case, that the patient has this complication. If this has happened in the first minute, you sutured, you left the room to answer a call, you came back, or the patient went to the toilet and came back, and your suture is torn, you resuture it back. So this complication is immediately solved. If the patient comes after 1 week like this, you definitely cannot suture it back. So you have to expect for secondary healing to take place. And you want to make sure the oral hygiene instructions are done very carefully and meticulously, and a lot of hyaluronic acid prescribed for the patient, and so forth. If the patient comes after 1 month with this scenario, you definitely are looking at more serious medical. If the patient is on bisphosphonate, if the patient is anemic, then you look into PRP and PRF procedures. You look into low-level laser to stimulate the growth. You look into, again, meticulous warm saline and hyaluronic acid. So the power of when is very important when a complication which is coming from a suturing department is affecting you. So 1 minute versus 1 week versus 1 month, or any time. I just put these 3 times just to clarify. It's important to know when this is happening. The second scenario, if you look at this, you might say the complication of this case, again, if it's done just now, you place the implant and you're looking at it, or you did this 1 week ago and the patient has come for suture removal, or you received this from another doctor who is saying, you know what, I'm not comfortable in restoring this. I would like to refer this case to you. I did this 1 month ago. There's a difference how you want to tackle the complication. Now, many of you might say, this is a placement department problem. And I think you have to reconsider, this is an osteotomy problem. So if you are mastering an osteotomy, this will not happen. Even though it might look at the beginning at it's a placement problem and you're weak in placing your implant. No, you're weak in osteotomy. And you have to practice your knowledge, skill, and experience in improving your department of osteotomy. Now, again, here, it's very, very interesting, this slide. Why? Because you think that this implant was placed higher and it got stuck, and it's a placement problem. Again, if you see there is a fracture screw inside, that means the osteotomy was not sufficient. The implant could not get in, and the carrier broke. They tried to remove the carrier, the broken screw. They damaged the wall of the implant from inside, and it's become flat. There are no threads. So now you're looking at, again, osteotomy issue. Just because you mastered every department, you know exactly why it happened. So when you are placing an implant on this case, again, you make sure you go wider in your osteotomy, and the bone, maybe it's very hard in this corner. Back to the 7-story building. So basically, I'm emphasizing on the understanding every step and every floor. And that's the key, how we predict and we can manage our complications in a better way. Now, why this presentation is important? Because the phases of diagnosing the complication is an issue. And what we are trying to do here, we are trying to answer all the 3 phases in this skeleton that we are creating. One is the type and the frequency of the implant-associated complications will be solved in this methodology. Then the risk factors will be clear, and then how to avoid it. So we are addressing all the 3 elements. Just to end today's session, I will show you a case. A patient comes with a panoramic x-ray from somewhere else, saying, I'm uncomfortable with the bridge. And being an implant dentist, of course, we think because the bridge is flexible and it's causing stress on the periodontal ligament distal wall, the second molar is tilted, so there's a pocket formation and the patient is uncomfortable. We take a CBCT, we look for the bone, we plan the surgery, we place the implant, the patient is still having problem. We send the patient to a specialist, do a root canal, still the patient has the same discomfort. We look into the CBCT more carefully. We find from day 1 there was a subgingival decay on the root of number 5. So this patient did not need the implant. She did not need the root canal. She just needed a cervical erosion, filling subgingivally. And if that was done, her old bridge would have still been there. There was no reason for the root canal. So I'm telling you, once you understand every step properly, the chances of you doing a complication will be minimized. And thank you for today's session. I'm ready for the question and answer.
Thank you, Dr. Souheil. Once again, good evening, ladies and gentlemen. It's a pleasure to have you as our participants. We would appreciate if you let us know how you felt about today's course. You can put down your comments in the chat box if you felt it was a fantastic session. We would love to hear you saying it was a fantastic session. If you would, oh wow, thank you, ladies and gentlemen. We like those messages, and those keep us to go, and those help us to keep continuing more sessions for you. Ladies and gentlemen, quickly, we'd be also running a quick poll. I'd like you to answer the poll before we move on to the question and answer session. In the meanwhile, I would also like you to note down your questions in the Q&A box so that we are on time and we do not waste any time. Once again, it's a request for you to kindly post your questions in the question and answer box. Thank you, ladies and gentlemen. Thank you for your lovely comments. All right, Siddiq, I request you to kindly end the poll. Dr. Sohail would love to answer to all your questions. I request you to kindly post your questions in the question and answer box. Ladies and gentlemen, it is we, DentistChannel.Online, your dental media company. We request you to kindly subscribe to DentistChannel.Online so that you stay in touch with us, so that we'd be able to help you to understand what's new in dentistry, about the upcoming courses, about the upcoming workshops that we've specially planned for you, dear dentist. Kindly subscribe to DentistChannel.Online. You can also look up to our official website, www.dentistchannel.online, so that you stay tuned with us, so that you get to know more with what's happening in the world of dentistry at one single roof. Please subscribe to dentistchannel.online. Well, for the ones who want to know more about the course, we'd be running an online course on the same topic, which is complications and solutions in implant dentistry. However, this course is only and only for interested students who wish to learn the methodology on how to find a solution to implant dentistry cases. This is going to be a program which would be having a mode of learning that would be online, like the one that we had today through Zoom presentations. It's going to be an online program, and hence I request you, if you want to know more about the course, you can WhatsApp us on the below mentioned WhatsApp number. We'd be able to give you complete details about the course, when it's going to happen, uh, and everything that happens along with the course. Like I've mentioned, the course will give you an insight on how to get the methodology on how to find a solution to every possible complicated implant dentistry case. Dr. Sohail himself is going to be the course conductor. And for that, if you wish to know more about the course, you can get in touch with us by WhatsApping us on the below mentioned WhatsApp number. Thank you, ladies and gentlemen. That was about the course and e-certificate of participation for attending this webinar would be given to our DCO Prime members only. I request you to become a DCO Prime member. If you are not a DCO Prime member yet, you can, for that, also mention us on the below mentioned WhatsApp number. As for DCO Prime members, you can message us your name and the name of the course on the below mentioned WhatsApp number. This is about the next webinar. The next webinar is going to take place on the 4th June 2020 at 5 p.m. Indian Standard Time. The topic is All on X with nasal, pterygoid, and zygomatic implants. If you're interested to be a part of this webinar, please do register for the webinar. You can find the link to the webinar in the chat box as well. Thank you, Dr. Souheil. We now start with the question and answer program.
Sure.
Starting with the first question. Question from Dr. Rupanjan Roy. How to handle when there is a problem with the angulation of the implant post-placement?
That's what we go back to the time. How post? Is it 1 minute post, 1 week post, 1 month post? When we know when it happened, we go back to the protocol and we have an answer. So the importance of time, the power of time, we said, that's the key to the answer. If it's integrated, then we just prosthetically, we have solutions with multi-unit abutments, with angulated abutments, and we just correct the angle. If it's done right then, we just remove the implant and make a new osteotomy and place it in the right place and fill the gap with particulate bone. So the question is when?
Thank you, sir. Next question. Question from Dr. Payal. Is there any devitalization of adjacent teeth?
Is there any devitalization of adjacent teeth? Is there a possibility of devitalization adjacent teeth? That can be a question. Yes, there is a possibility of devitalizing teeth if you damage the wall, and that can lead to a future iatrogenic RCT treatment, which the patient didn't need, but now you have to do a root canal treatment. Most of the time, the root canal treatment will suffice, and you don't have to remove the implant. And it depends on how much of a periodontal ligament is touching the surface of the implant. Mostly when you just touch the tip of the natural tooth, you can get away with just doing a root canal on the natural dentition. However, if that damage or trauma to the natural dentition creates a periapical infection, then plus the root canal that you have to do, also your implant will de-osseointegrate or not integrate, and the implant has to come out, or it will eventually by itself create a fiber encapsulation, and you have to do it properly on a. But if you have taken a periapical x-ray, as we discussed the steps, you will see on the first drill that where your implant is going to go. So the answer to the first question and the second question both are relevant to the steps that you didn't follow, which is taking a periapical x-ray, which is one of the 12 steps in placing an implant. So one department is not there in your building, and that has to be developed in your implant dentistry building.
Thank you very much, sir. We move on to the next question. Question from Dr. Gaurav. For indirect sinus lift procedures with implants in molar region, for how long we have to wait ideally for osseointegration to happen to avoid any complication?
Generally, we should look at biology. We know epithelium grows 1 millimeter a day and bone 1 millimeter a month. So as an average, 2 to 3 months is enough if you have primary stability in the maxilla. However, there are devices, which is ISQ. You should apply that in the maxilla, especially if you did a sinus lift. prior to do uncovery and restoration. And if that machine shows you anything below 65, then you should wait till you get that number.
Thank you, sir. We move to the next question. Question from Dr. Sonal. How to handle if an implant impinges an anatomic structure like nerves or the atria?
That's it. Again, you have not taken a periapical x-ray at the first drill. So all this can be avoided if you follow the skeleton that we are suggesting. So you have done an irreversible damage, and it was iatrogenic 100%. This is not the patient's fault. This is not external reasons. This is not due to time. All these elements that we said, economy, the payment, the equipment, this is totally 100% because you did not uh, take a periapical x-ray after the first drill. So you've damaged something, you remove the implant, or I don't know which stage you are. If you've placed the implant, then remove the implant and wait for the body to heal. If you don't have access to low-level laser therapy, refer them to a person who's expert in that. Generally, the sensation comes back very quickly with low level. And after that, when the area heals, you place your implant. If you are not confident in the posterior mandible, then use stopper drills, because then you cannot go further than where the stopper is stopping the drill from going. And a periapical x-ray at the first drill. This is basically how you don't fall into the same mistake again. You learn from it, and it doesn't happen in your office ever again.
Thank you very much, sir. We move on to the next question. This is a question from Dr. Ramesh Kumar. Many of the implantologists suggest not to place bridge, that is 3 crowns on 2 implants. What is your view on this statement?
Well, according to the literature, the difference in the success rate of a 3-unit bridge and a 3 single implants next to each other on single crowns are very close. So there is not, statistically, there is no difference in terms of success rate. Um, it's like 3% different, which is clinically not significant. So if the patient can afford it, if the bone is there, you can place 3 implants. If for financial reason or the quality of the bone is not permitting 3 implants, if you place 2 implants with a 3-unit bridge, the result is the same. So I don't know why you say implantologists, they agree on that fact is not being published, that implantologists do not, they prefer this versus that. I don't know if that fact has been ever published. So I think they are equally um, uh, reliable treatment plan analogies and methodologies. It's based on the case where you and the patient sit down and decide which one you want to do.
Thank you, sir. 2 more questions. Next question, Dr. Sakshi. In case where healing screw was exposed, how osteotomy was wrong, kindly explain and how to deal this problem by opening flap and again putting bone graft.
If this is on the occlusal surface, I don't think any bone graft will hold. Only bone graft will hold on the buccal surface. So if you're talking about cover screw, you're talking about the occlusal surface. So anything on the occlusal surface where the neighboring bones are lower, and you just add a mountain of bone, that will not hold. So there is no reason to add any bone. And if it's exposed, no problem, because the cover screw, if the implant was not placed, again, you remember I think there was number 10, the placement. If the placement was done according to the protocol, some implants suggest to place them 0.75 below the bone level. If that was placed in 0.75 below the bone level, then that's it. Then you just, if the soft tissue is thin and the cover screw is exposed, so what? Let it be exposed. But if you didn't follow the protocol and the implant was suggested to be at the bone level and you placed it above the bone level, then it's your, again, it's an iatrogenic mistake that your implant placement department was weak and you did not place the implant in the right place. And next time you make sure you follow the instructions of this implant to be placed flush with the bone, and that's it. So if depends, uh, that's why once we are done with all the formulas in this group, and then people register for the course, they become the real students of the program. Then once we have all the formulas in front of you, then you will bring the case with the time when it happened, and then automatically you fit this problem into the right place, and we all can easily come to consensus that this has happened and this will not happen again, because we know we have to do this and this and this, and for this scenario we will solve it this way. It cannot be generalized statement that cover screw is exposed, what should I do? Which stage caused the cover screw to be exposed? That can be easily seen if the doctor explains all the steps, the 12 steps, where they made a mistake. And then we can address that mistake.
Thank you, sir. Last question from the live question and answer round. Is there, if there is screw loosening after crown placement, how should we manage?
Screw loosening, abutment screw loosening, I think he or she meant. Abutment screw loosening, generally, if you're using a hand to torque it down, then you have to get the right tool and torque it down to the 30 Newton or 32, or depends on the company. That's the first step. Many people use their hand. They think they're strong enough, which is not true, because there is a lot of literature on you have to use a torque device to tighten it down. And there is enough evidence to show which kind of torque device is reliable and which one is not reliable. So first of all, imagine we use the torque device, not a hand, and the abutment has become loose. The second reason biomechanically is the occlusion. If there is a cusp on this uh, restoration which is higher than where it should be, it will create always this kind of it helps the screw to unlock itself from its position. So then you have to check occlusion and eccentric and forward and backward, and make sure that there is no higher cusp when the patient goes to lateral trousseau. Once you correct the occlusion, then you do it one more time. And again, if it becomes loose, then maybe you should change that screw. Maybe that screw is already been damaged. You put a new screw. Now, these are two questions. One is, in multi-unit abutment, you have two screws. One is screwing the framework to the multi-unit abutment, and there is a screw which is tightening the multi-unit abutment to the implant. Now, again, each one has a different torque. So I don't know which screw is loose, but each one can be fixed according to the etiology. Generally, it can be fixed because it's a mechanical, there is a hole and there is a screw. You tighten it. If the occlusion is correct, we know maximum we can bite is what, 20 kilograms, 25 kilograms. That's the maximum if you are like a 6 foot tall and you have a lot of muscle. So in a general scenario, we can always fix this issue.
Thank you, sir. That brings us to the end of the live question and answer session. Once again, on behalf of Team DentistChannel.Online, I'd like to thank you specially for your time and for the lovely presentation, and also to our participants for giving us the overwhelming response. We really appreciate it. As for the ones who've mentioned that they are interested to know more about the course, our team members would be getting in touch with you shortly. We would be also sending you an email or a WhatsApp message. So if you're interested, you can register for the course and you can know more about the course by you WhatsApping us on the WhatsApp number that was mentioned earlier on the screen. That brings us to the end of the live webinar. Thank you, ladies and gentlemen. May
Thank
you
you.
all
Thank you
have a
very much.
great evening.
Appreciate it. Thanks.
Thank you,
Have
Doctor.
a have a good day, everyone.